Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
When it comes to cancer, having the right information can make all the difference. Of course, it's critical to have the right diagnosis and as much information you can about that diagnosis. That's why researchers are constantly looking for new ways to better understand cancer and create tools that help doctors make the best treatment decisions for each and every patient. Today, we'll be talking about some exciting discoveries that are helping to do just that. One is a new tool that's making it easier to choose the best treatment options for women with breast cancer. The other relates to artificial intelligence and a breakthrough to improve how doctors study the immune system and immune response in the treatment of melanoma, which I think, as most of you know, is a type of skin cancer, the most worrisome type of skin cancer. Our guest tonight is Dr. David Rimm, who will explain how these tools work and how they're helping to make cancer care more personalized and precise. David is a pathologist. He is the Anthony N. Brady Professor of Pathology at Yale School of Medicine. And he is perhaps first and foremost a cancer researcher at the Yale Cancer Center. We'll be talking about some of his own work, and we'll be talking about pathology and molecular pathology in general. So, David, welcome. Thanks for joining me here tonight.
Thanks for having me.
So just to start off, I just want to ask you a couple of questions about pathology. And for the average listener, people are used to hearing about medical oncologists and surgeons and radiation oncologists, and when someone's going through cancer treatment, they meet all those people. Pathologists are sort of back somewhere else, but they're really critical. And maybe you can just tell us for a minute about how important, and you can toot your own horn, how important pathology is when it comes to cancer treatment.
Thanks for this opportunity, because in fact, nobody has cancer until the pathologist says so. That is, the definitive diagnosis of cancer is made by the pathologist, and any actions that are done by the oncologist or surgeons are based on that information from the pathologist. So even though a patient may never see us, their treatment is highly dependent on what we say.
That is absolutely the case. And I think that the best pathologists are the ones who are in regular dialogue with clinicians, with the people who are taking care of the patients, because without the right diagnosis, and it's not just the diagnosis, sometimes it's questions that come up along the whole treatment course. But without that, we as clinicians are somewhat lost. So you all are really, really critical. How did you decide to become a pathologist?
That's a great question. I initially thought I would be a medical oncologist or even some other specialty in medicine, but then I took pathology in my second year of medicine. And back then, when I was taking pathology, it was a major part of the second year. I just really loved it. And I thought, okay, this is what I think I also thought it was the discipline that was closest to the patient. That is, that it mixed science and patient care in a way that many other disciplines didn't, and also allowed time for the doctor to spend some time doing research. And so that's why I chose pathology.
And I'll just say to our listeners that as a clinician, I find working with great pathologists to be a complete joy. And it's something that helps so much when we take care of people. I just can't say how often it is that I speak to pathologists. So let's talk about the breast cancer test, and this is not the first that you have developed, but let's talk about your recent work in terms of looking at a new way of letting clinicians know perhaps what the best treatment approach would be.
Sure. So we've just developed an extension of a test that we've been doing for a while. And the idea is that instead of reading a tissue, which is what pathologists do when they look at it and give you their opinion, we're trying to measure, which is what happens in laboratory medicine when you get a blood glucose or something like that. And that is, we're trying to count the exact number of molecules for each, for various drug targets that each tumor has. And so that's what we've developed. And initially we developed for one target, that is HER2, which maybe many of your listeners have heard of before, because
and can I just jump in for a second?
Sure.
So traditionally, the way HER2 has been assessed is literally at the almost impression level. So HER2 is scored on a 0 to 3 plus scale, 0, 1 plus, 2 plus, 3 plus. And how subjective is that?
Well, we're really pathologists. Each pathologist does things a little bit differently, and we're really good at telling positive from negative. But lately, we've had to tell subtle differences in low range, and we're really bad at that. And so that's one of the reasons that we were working on this new test, is to try to answer questions about the levels of this protein when it's barely present, as opposed to when it's massively overexpressed.
And in truth, even when it's clearly positive, it's turning out that there may be important clinical differences, and actually having a little more quantification, in theory at least, might be helpful.
Absolutely, I agree. And that's another reason that we've been doing this.
So we've got HER2, that's one part of this test. And then there's something else called TROP2. Tell us about that.
Right. So TROP2 and HER2 are both targets that is, I like to call them like little tags on the cell. And they might have functions, but when you're using a new kind of therapy called an antibody drug conjugate, they're really just tags. That we're not so concerned about their function, but about their tagging. And so the thought behind antibody drug conjugates is the more tag you have, the more drug you can bring to the cancer cell. And so it's important to know how many tags you have. And it's important, in my opinion, to know what color those tags are, if you will. That is, it is a TROP2 tag or is it a HER2 tag? Because whichever one you have more of, theoretically, that would be the one that should go to that patient first, so that they can have the best chance of benefiting from the drug. And so TROP2 is one of the tags that has been less carefully assayed in the past compared to HER2. But what we've done is made an assay that can tell us essentially the number of molecules of TROP2 and the number of molecules of HER2 on the cancer cells, so that the oncologist should be able to use that information to decide which of those two antibody drug conjugates to give first.
And I realize you're not a medical oncologist, but all of this has become more important in the era of these antibody drug conjugates. And do you want to just explain to our listeners what an antibody drug conjugate is?
Sure. An antibody drug conjugate, I think, is a real breakthrough in that it connects an antibody, which is a way of finding a specific tag on a cell, to a drug that's so toxic that if you gave it to the patient without some sort of linkage, it would be too toxic to give and the patients would have a bad response. So by connecting it to an antibody, you only deliver the drug just to the tumor cell that has the tag on it. And that method, as long as the drug doesn't get off of the antibody, allows you to deliver a lot of very toxic drug to just the tumor cells, as opposed to having complications with that toxic drug reaching the whole patient's systems.
So it's a little bit like a Trojan horse or a delivery truck. The antibody is the delivery truck, and when it gets inside the garage being inside the cell, that it releases the payload or the chemotherapy drug that could be very toxic, and it's in that very specific place that it releases it. Am I getting that right?
And that's the exciting part about it, is that you can give, since you have that sort of delivery mechanism, you can give a much more toxic drug and much more likely to kill the cell and kill the cancer than you'd otherwise be able to give by regular infusion.
Now, to make this just a little bit more complicated and a little bit more confusing, both for us and for patients at times, some of these antibodies in and of themselves have a therapeutic impact and some don't. So, for example, when we talk about antibody drug conjugates that are focused on HER2, antibodies to HER2, which are drugs like Herceptin, actually have a therapeutic value, whereas TROP2 antibodies are just truly the passive delivery truck.
Yeah, I think that that's a really important distinction. Although, and I might point out that delivery truck, there's about 260 of those delivery trucks in clinical trials now. So I think this is going to be very important to be able to select the right address for the delivery trucks in the future.
Yeah, no, this field has just absolutely exploded. So, using this combined test you have, looking at HER2 and TROP2, how would you imagine that would help doctors make decisions, help patients get better treatments?
Well, I think it's all about precision medicine or personalized medicine, is that every cancer has a different biology and expresses more or less of HER2 or TROP2. And so I think that in order to have truly personalized medicine, you need to know that patient's, what level of tag that patient's tumor expresses. And then if you know that level of tag, you can choose the right drug in which the patient has the most tag.
So with this one test, you could say there are a lot more TROP2 tags than HER2 tags, which would then prompt the clinician to give the drug, the antibody drug conjugate that uses TROP2 as the delivery mechanism.
Exactly. That, and in the future, other pairwise tests to look at which tag is the most frequent in the patient's tumor.
And this is talking about breast cancer, but of course, we're not just talking about breast cancer, because of those hundreds of antibody drug conjugates, only a small fraction of them are for women and occasionally men with breast cancer, and they're for all sorts of different diseases.
Right. So that's why I think this assay will have utilization beyond breast cancer, but we're starting with breast cancer.
And are you developing similar assays using other targets?
Yes, we've gotten a tag for EGFR is another tag we're looking at. HER3 is another tag. Head and neck cancer and lung cancer have drugs in both of those tags. So we're looking forward to expanding the concept of a specialized assay that's quantitative and can pick which tag is the correct tag for each patient's biology, and not just in breast cancer, but in essentially every tumor type where there are antibody drug conjugates.
Okay. Well, we're going to have to take just a brief break. When we return, we'll continue our conversation with Dr. David Rimm, a pathologist at Yale School of Medicine and a very creative investigator who's been developing new tests. And we'll talk a little bit more when we come back about actually melanoma.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, which provides a multidisciplinary approach for treating appendix cancer, including advanced surgical techniques like hypothermic intraperitoneal chemotherapy. Learn more at smilowcancerhospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone, there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting even after decades of use can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as the BATTLE-2 trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again, and welcome back to Yale Cancer Answers. I'm Eric Weiner, and tonight I'm speaking with Dr. David Rimm, a cancer researcher and the Anthony N. Brady Professor of Pathology at Yale School of Medicine. We just spoke about a new personalized test that will help doctors choose therapies for women with advanced breast cancer. And a test that, with some modifications, could be useful in the treatment of a variety of different cancers. So we're now going to switch gears, and we're going to talk about melanoma. David, you recently did some work that was published in JAMA Open Network about the use of artificial intelligence, which of course is just exploding in our lives and certainly in medicine, but using AI in helping to make decisions about the treatment for patients with melanoma. And in fact, comparing to what AI can do versus what a pathologist can do without AI. And maybe you can tell us a little bit about this.
So the study was a study of melanoma tissue specimens on glass slides, and they were all scanned in so that we were looking at digital images. And then we had a machine that we built a little while ago that could identify using AI the tumor cells versus the lymphocytes versus other stuff. And the hypothesis is that if you have more lymphocytes per tumor cell area or per slide area, you're more likely to do better and have better outcomes. And so what we did was had a bunch of pathologists do their reading as they normally would to estimate the amount of lymphocytes. And then we had our machine operated by some pathologists, but sometimes operated by scientists, just run their machine learning to run the machine to determine the number of lymphocytes. And what we found is that that the machine was equivalently accurate to in terms of predicting outcome, but a lot more precise, meaning that all 60 of the people that used the machine had a very tight opinion about each slide, whereas the pathologists had somewhat more spread amongst the 30 different pathologists that read the slides. There was more variance. And so again, this is sort of a question about accuracy and precision given by using a measurement as opposed to using a subjective estimate.
Doesn't surprise me. Maybe you can explain to our listeners what tumor infiltrating lymphocytes are.
Sure. So whenever there's a tumor, the pathologist looks at the slide and they can see tumor cells, but they can also see a number of other kinds of cells on the slide that's stained with just the routine hematoxylin and eosin stain. And one of the most prominent other cell types are lymphocytes, and those are the cells that run the immune system and actually are thought to kill the tumor, as well as being next to the tumor. And when there's a lot of them, needless to say, that are more likely to be successful than when there's only a few of them. So it's important to know how many there are, and that is useful information to determine the likelihood of the tumor being aggressive or recurring versus the tumor being cured by the resection.
And does that also help us predict which patients are going to have a better or worse response to immunotherapy?
Yes, it's been used for that as well. Our application in this case was the thought that should the patients after their surgery get immunotherapy, which is a pressing question in melanoma now. That is, they get their melanoma removed by the surgeon, and then there's the option for the oncologist to give immunotherapy if they think the melanoma is going to return. But immunotherapy isn't without its toxic side effects. And so if we could figure out a way with a high sensitivity and specificity to determine which patients need immunotherapy and which patients don't after their surgical resection, then that would be a valuable tool. And that's what we've done. We've just have proof of concept at this point, and all the data is retrospective. So I think the data is sufficiently compelling that we should now try to use this test in a prospective setting.
And you touched on the side effects of immunotherapy. And as I often tell patients, immunotherapy is either a total walk in the park and has very, very few side effects. But for a minority of patients, a relatively small minority, it can have really severe side effects. And I think that's the dilemma that many of us face. And particularly in the hands of a melanoma doctor, this decision-making is particularly challenging, partially because our treatment of melanoma has advanced so much that even if the melanoma recurs, patients can then often do extraordinarily well. And so it's a decision of, do you give them the immunotherapy up front, or do you wait to see if you're going to need it later? So does this mean that pathologists will be out of business and that they'll just be replaced by artificial intelligence tools?
So I've heard that comment from many people, and there's been many technologies that were going to replace pathologists, but yet we're still here. And so my answer to that question is that pathologists will not be replaced by artificial intelligence, but they will be replaced by pathologists that use artificial intelligence. And so I think that it's important to understand that it's a tool like many other tools that pathologists have in their toolbox, and pathologists that don't use artificial intelligence will be replaced by those that do.
I think that is extraordinarily well put. I think it's true of radiologists. For that matter, I think it's true of medical oncologists. I think we can be way smarter using artificial intelligence than not using it. But there's still a need for the doctor in the room. And I think this is really, really a critical point. So what are the challenges that you see pathologists facing as they're beginning to use these new tools? And I imagine one of them is just there are some people who are resistant because, as a friend of mine always says, all change is to be resisted, at least by some people.
Yeah, that's certainly true. And pathologists are not the most rapid discipline to pick up new tools, as you know. And so I think it's important that pathologists, and especially junior pathologists, are picking this up. Certainly digital natives, the young pathologists that are now in training and early in their careers, are a lot more amenable to the use of artificial intelligence because they've been using digital tools their whole life. Whereas us older guys, we didn't start using digital tools until later in our careers. But I think it's going to be critical. But again, it will never replace us because you can't sue a machine. There has to be someone that takes responsibility and has liability for patient care, and machines can't do that.
You know, one of the things that's been said at times is that with AI, a pathologist can potentially sign out that many more cases in a given day, and I have no doubt that that might be the case. When we worry about physician burnout and burnout of everyone in our society, I think one of the concerns that's been expressed is that having this higher volume of work could in and of itself contribute to burnout. Any thoughts about that?
Yeah, so that's, I think, a really powerful use of AI in pathology that's just now coming online that allows us to only look at the interesting parts. So using AI, a number of companies have figured out a way to sort of color in the interesting parts that we need to look at and leave the other parts uncolored so that we can ignore anything except what's colored in, and then we focus in on that part. And by doing that, we might only have to look at 1/10 or 1/50th the number of cells that we have to look at today. And so I think that's one of the most powerful tools, will be sort of focusing the pathologist's effort on where the most important pathologist judgments are required, as opposed to spending a lot of time looking at normal tissue.
I think that speaks to the fact that the real goal, I think, with AI might be a little bit to do work more efficiently, but it's also just to do work better. And if all we get out of it is doing work better, that in and of itself is really huge. So both this work related to AI and the test we were talking about before in terms of quantifying HER2 and TROP2 are ways that we can begin to further personalize care for patients. And how do you think that's going to play out over time, and the whole role of more personalized, more individualized, more tailored therapy in cancer?
Yeah, I think, we've been seeing tailored therapy for 20 years now, and it just keeps getting better and better. And I think initially most of the most impactful tailored therapy were when there were drugs for specific mutations, and then you test the patient by DNA sequence to see if they had that mutation. And if they did well with that drug. That's the first generation of personalized medicine, and it's been extremely successful and valuable to patients. I think the next generation will go beyond DNA sequencing and start looking at post-translational modifications, or start looking at proteins or other things that also personalize tumors like and can pick the right therapies like the tags on ADCs. And I think that's sort of the next generation of personalized medicine. And I predict it will have the same value that the first generation of personalized medicine had.
And just following up on what you just said, could you just explain what post-translational work is about?
So the dogma is that DNA makes RNA and RNA makes protein, and that's sort of the central biology of all tumors. And so if you look at the DNA, that's kind of the first step, but it's the furthest away from function. But it's been the most successful for personalized medicine. So now we get closer and closer to function using more and more sophisticated tools to measure things that are harder and harder to measure, like post-translational modifications and like protein quantities, which we're now just now being able to measure accurately, as we discussed in the first half of the show.
Yeah. And then, the other piece of personalized or tailored therapy is related to tailoring to the host, meaning the person, not just to the tumor. Because, the funny thing about cancer is both self, meaning part of you, and in some ways not self, because it's become this sort of monster, if you will. Not that all cancers are such monsters, but then there's this piece of the person themselves, and the fact that different people react very differently to different therapies. And I'm not talking about people's personalities, but people's DNA and RNA and what have you.
Yeah, I think that it'll be very important in personalized medicine to not only personalize the medicine to the tumor, but to personalize the medicine to the patient's response. And as you know, we all respond a little bit differently. That's why some patients suffer great toxicity and others less so for any given therapy. And so we need to begin looking at the response as well as the primary tumor for methods of personalizing medicine.
Dr. David Rimm is the Anthony N. Brady Professor of Pathology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.